Good morning everyone once again. Can you hear me? Okay, let's start. Okay, Parag beta. So thank you very much for confirming. So we'll start our lecture. I'm Dr. Arvind Arora, taking crash course of orthopedics for undergraduate students for their final MBBS examination. And this lecture I'm taking on behalf of Department of Orthopedics, SAID GS Medical College and KEM Hospital, Mumbai. And this lecture was advised by my head of the department, Dr. S.K. Shrivastava. So we have finished bone tumors and metabolic bone disorders. Now we will discuss the next chapter, joint disorders. And whenever in orthopedics we are talking about joint disorders, we are mainly concerned about synovial joints. As you all know, there are three types of joints, mainly fibrous, cartilaginous and synovial joint. So whenever we are talking about joint disorders in orthopedics, we are mainly concerned about synovial joints. Now I will give you a brief idea of synovial joint, which are the main part. Synovial joint is usually found between articular surfaces of two adjacent bones. In complex joints there may be more than two bones. So these are the two articular surfaces of bone. These will be covered by articular cartilage. So this is articular cartilage, which is a type of hyaline cartilage. Now the outer fibrous protective covering is fibrous capsule. So this is capsule of the joint. And inside the capsule there will be a lining known as synovial lining, which will be lining the joint everywhere except over articular cartilage. So this is synovium or synovial membrane. So these are the important parts which you should remember: articular cartilage, which is a hyaline cartilage, synovial membrane and capsule of the joint. Now on X-ray, whenever you are taking X-ray, for example of knee joint, this articular cartilage, this is a soft tissue, you cannot see cartilage on X-ray. So this area which is occupied by this cartilage, it will be seen as joint space. So on X-ray, whenever you are taking X-ray of, for example of knee joint, we are talking about joint space. That joint space is nothing else but the area occupied by this articular cartilage. And whenever there is destruction of articular cartilage, the thickness will decrease. So this joint space will be decreased. And in all joint disorders, either sooner or later, there will be damage to this articular cartilage. So in all joint disorders, either sooner or later, there will be decrease in joint space. Okay. So these are the important structures in a synovial joint. Now types of joint disorders. Joint disorders are mainly classified into degenerative, inflammatory, infective and hemorrhagic. So degenerative joint disorders, where the damage in the joint is due to mechanical wear and tear, due to mechanical stresses, and the most important example is osteoarthritis. In inflammatory disorders, there is active inflammation in the joint, which is the starting event. So inflammation is the starting event in the joint destruction, and the prototype of inflammatory disorders is rheumatoid arthritis. Other examples are seronegative spondyloarthropathies like ankylosing spondylitis, psoriatic arthritis, enteropathic arthritis, or Rhetus syndrome. Other important example is crystal induced arthritis like gout and pseudo gout. These deposition of crystals lead to inflammation inside the joint. So these are the inflammatory arthritis where active participation of immune system of the body causes inflammation in the joint, and that is the triggering event in the joint. Now in infective arthritis, either we can have pyogenic infection leading to septic arthritis, or we can have non-pyogenic infection like tubercular arthritis, that we are going to discuss in chapter of infections in orthopedics. And hemorrhagic arthritis, recurrent bleeding in the joint lead to damage to joint, that is hemophilic arthropathy. Now today we are going to discuss three important joint disorders which are considered as a major joint disorder, which are very important for your university exam as well as for your PG entrance exam: osteoarthritis, rheumatoid arthritis, and ankylosing spondylitis. So let's start with this. First one is osteoarthritis. Osteo means bone, arthro we use for joint, itis we use for inflammation. Okay, so in our slide we have discussed osteoarthritis is a degenerative disorder, not included in inflammatory type of arthritis. Now there is one catch in this. Osteoarthritis does not mean that there is no inflammation in the joint. Inflammation does play a very important role in the pathological process or destruction of the joint, but that inflammation is not the initiating event. Okay, in inflammatory arthritis, the first initiating event, triggering event is inflammation. First there will be inflammation, then there will be destruction of joint. Whereas in osteoarthritis, first there is start of damage to the joint, secondarily there will be some inflammation which will also destroy the joint. So inflammation does play some role in osteoarthritis. Okay, so usually we consider that as a misnomer because inflammation is not there, non-inflammatory arthritis, but actually it is not a misnomer. Inflammation does play some role, that I am going to tell you in pathology. So osteoarthritis is degenerative disorder of joint characterized by progressive destruction of articular cartilage. And reminding you, articular cartilage is hyaline cartilage covering the articular surfaces of two adjacent bone. It is overall the most common type of arthritis. And here also you should remember, you don't get confused, whenever we are talking osteoarthritis, we are talking about primary osteoarthritis. The osteoarthritis without any other pathological process. There are n number of causes of osteoarthritis which are called as secondary osteoarthritis. For example, any malunited intra-articular fracture will cause osteoarthritis of that particular joint, that is secondary osteoarthritis. Some foreign body in the joint, if you are using the joint with foreign body, it will also damage to the joint, that will be secondary osteoarthritis. So here we are talking about primary osteoarthritis, and this primary osteoarthritis is due to repeated mechanical stress in the joint. So this is a wear and tear disorder. Repeated mechanical stress leads to damage to the joint. Now we will see what is the pathophysiology. The most important risk factor for primary osteoarthritis is age. With increasing age, there are more chances of damage to the joint. And the primary pathology, primary target of the disorder is articular cartilage. So there is imbalance between cartilage formation and cartilage destruction, where cartilage destruction overweighs the cartilage formation. So what happens? Along with increasing age, continuous repetitive stress on the joint, particularly that articular cartilage, lead to chondrocyte injury. Now these chondrocytes, they will try to proliferate to get repair done. So they will secrete proteoglycan, collagenase, proteases, which will cause remodeling of extracellular matrix, and there will be increase in water content initially in the cartilage. So the earliest pathological change because of these trial of repair process will be softening of cartilage because of increased water content. So this cartilage will become soft, but as is primary osteoarthritis, there is no predisposing pathology. So we continue to use the joint because we cannot sit down. So we continue to use the joint, which will lead to further injury. So there will be repetitive injury, which will lead to further damage to the joint and inflammation in the synovial membrane. So at this stage, there will be synovitis also in the joint. So now you can see there is involvement of inflammation. Osteoarthritis, it is a non-inflammatory disorder. That does not mean there is no inflammation. Inflammation play very important role in pathogenesis, but that is not the primary triggering effect for primary triggering event for joint damage. It is the aging process which lead to chondrocyte damage. So mechanical stretch, it causes damage, which leads to development of inflammation. Repeated injury causes inflammation. There is further damage to chondrocyte and fragmentation of cartilage. So there will be first fragmentation in this cartilage known as fibrillation of cartilage. And if there is continuous injury, repetitive use of joint, there will be complete damage to that articular cartilage leading to exposure of subchondral bone. Now the whole load of the joint is coming to subchondral bone. So that subchondral bone will also react. So there will be formation of bone, excessive bone formation, subchondral sclerosis. There will be hibernation. That new bone, that will be chalky white, milky white, hibernation. There will be formation of bone at the margins of joint, that is osteophytes. And as there are microfractures also in subchondral bone, some of the joint fluid will seep into that microfracture leading to formation of subchondral cyst. So ultimately you can see there will be damage to articular cartilage, thin and fibrillated cartilage. Here you can see. There will be subchondral bone formation, that is a reaction to increased mechanical stresses, marginal bone formation, osteophytes, and due to microfracture in subchondral bone, the synovial fluid is going into the bone leading to subchondral cysts. So these are the various pathological features in osteoarthritis. Now which joints are involved in osteoarthritis? Once again I am telling, we are talking about primary osteoarthritis. Where is no primary pathology in the joint is there. Secondary osteoarthritis can involve any joint. Whenever there is joint pathology, that joint can be involved to cause secondary osteoarthritis. Here we are talking about primary osteoarthritis. And joint involved in primary osteoarthritis in hand joint, it involves distal interphalangeal joint, proximal interphalangeal joint, and first carpometacarpal joint. There will be typical sparing of wrist joint and metacarpophalangeal joint, which are involved in rheumatoid arthritis. And how to remember this, I will be telling you along with rheumatoid arthritis. There will be sparing of elbow joint also. There is typical involvement of knee and hip joint with sparing of ankle joint in lower limb, and in spine, cervical and lumbosacral area are involved, which is known as spondylosis. And whenever we are using the term spondylosis, cervical spondylosis, lumbar spondylosis, that is nothing else but the osteoarthritis of spine. And one characteristic feature of osteoarthritis, especially osteoarthritis of knee, which is the most common joint involved in osteoarthritis, followed by distal interphalangeal joint. Okay. The characteristic feature is asymmetrical involvement of joint. In knee joint, it is the medial part of joint which is involved earlier and more severely. Why is it so? As we have discussed, this is a mechanical disorder due to repetitive mechanical stress. So part of the joint which is having more mechanical stresses will be involved earlier. So here you can see in this figure, this is knee joint and mechanical axis of lower limb, that is the axis through which weight is transmitted in the lower limb is slightly medial to the, this is medial side, slightly medial to center of rotation. So more mechanical stresses in day-to-day life are on medial side of the joint. So there will be destruction of medial side of the joint is more than lateral side. That is why most of the time in osteoarthritis you will get genu varus, because medial side of joint is destroyed more than the lateral side. So asymmetrical joint involvement is characteristic in osteoarthritis. In contrast to inflammatory arthritis, like in rheumatoid arthritis, which is an inflammatory disorder. So it will not differentiate various part of joint. It will involve, the inflammation will involve the whole joint simultaneously. So there will be symmetrical involvement in rheumatoid arthritis. Now clinically, the patient will be presenting with mechanical type of pain. Because it is a mechanical disorder, mechanical type of pain. So what is mechanical type of pain? Mechanical pain is pain which increases on activity and weight bearing and relieved by rest. So this is mechanical pain. Whenever there is mechanical stress, there will be pain. As soon as you take out mechanical stress, the pain will be relieved. So pain on activity and weight bearing, relieved by rest, mechanical pain, typical symptom of osteoarthritis. There may be crepitation, and in knee joint there will be typical varus deformity, as we have discussed, because medial side of joint is destroyed more than the lateral side. In some of the small joints of the hand, there are palpable nodules due to formation of bone. Haberden node at distal interphalangeal joint. Here you can see distal interphalangeal joint, Haberden node, and Pochart's node on proximal interphalangeal joint. So how to remember? High definition blood pressure. High definition Haberden node, distal interphalangeal joint. Blood pressure, Pochart's node, proximal interphalangeal joint. So these are the palpable nodes in small joints of hand. On X-ray, the earliest finding will be decrease in joint space, and it is on medial side more than the lateral side. As we have discussed, joint space is nothing else but the space occupied by articular cartilage. Articular cartilage you cannot see on the X-ray because it is soft tissue, and if it is destroyed, that space will be decreased. And the primary target in osteoarthritis is articular cartilage. So earliest manifestation will be decrease in joint space. There will be subchondral sclerosis. Here you can see subchondral cysts. Here I cannot see any cysts. Yeah, here there will be osteophytes at joint margin. Here you can see these are new bone formation osteophytes, and in knee joint you will get varus deformity. These are the important radiological findings. Earliest finding is decrease in joint space. Treatment, we always start with conservative treatment in the form of anti-inflammatory drug along with physiotherapy plus activity modification. Okay, so we ask the patient, don't do ground level activity, don't sit cross leg, don't do squatting, to decrease mechanical stresses on the knee joint. And we give anti-inflammatory. We start doing physiotherapy to strengthen the muscle around the joint. If patient is improving, we go ahead with conservative treatment with activity modification. If patient is not improving, then surgery is required. And here we will discuss the surgeries for knee joint, where we do surgery for osteoarthritis most commonly in India. So if there is osteoarthritis of knee, we do conservative treatment. If patient is improving, we carry on. If patient is not improving, then surgery. And type of surgery usually is guided by the age and the number of compartments are involved. If the age of the patient is less than 50 years and both should be fulfilled, only medial compartment is involved, which was the earliest compartment involved. Okay, so if age is less than 50 years, that is younger patient, and only the medial compartment is involved, both should be fulfilled, then either we do high tibial osteotomy or unicondylar knee replacement, where we replace only medial compartment of knee, UKR. If patient is more than 55 years or there is involvement of more than one compartment, like tricompartmental osteoarthritis, then we go for TKR, total knee replacement. I will be showing you the x-rays also for all these surgery for better understanding. So osteoarthritis, always initially conservative treatment, anti-inflammatory, physiotherapy and activity modification. If improvement, carry on with conservative treatment, physiotherapy. If there is no improvement, patient is young, less than 55 years and only medial joint is involved, high tibial osteotomy and unicondylar knee replacement. If either age is more than 5 years or all three compartments of knee joint are involved, total knee replacement. So here you can see this is high tibial osteotomy. As you see, a medial joint space is reduced, and whenever patient is bearing weight, as medial articular cartilage is damaged, due to that the mechanical axis will be more medially. Here on this side, here on this X-ray you can see medial joint space is gone. This is weight bearing X-ray. So mechanical axis will be passing here. So whenever patient is bearing weight, it will be like this and there will be severe pain. So what we do? We do medial opening wedge osteotomy, high tibial osteotomy, high in tibia we open the medial wedge. So what we'll do, if we do open medial wedge osteotomy, this mechanical axis will come slightly laterally. So whenever patient is bearing weight, it will come on lateral side more. So here you can see now on this side weight is not coming. So there is not touching of bone to each other. Though there is cartilage damage on this side, though there is joint space reduction on this side, but on weight bearing, as the mechanical axis has shifted to lateral side, the weight is transmitting to this area. Now you can see this is weight bearing X-ray. Here the lateral joint space. Here see this lateral joint space is reduced. So now the mechanical axis is shifted laterally. So weight is transmitted laterally. So there will be no pain to the patient. So this is high tibial osteotomy. The other option for young patient and only medial joint involvement is UKR. Only medial compartment of joint is replaced. So these are the options in young age. Now if patient is more than 55 years or there is involvement of all compartments of the joint, we do total knee replacement. Okay, here this is total knee replacement. Okay, so always try with conservative management. Patient is improving, conservative management not improving. Patient is less than 55 years and only medial joint spacement, either high tibial osteotomy or UKR. If patient is more than 55 years or there is tricompartmental osteoarthritis, TKR. Now the next important joint disorder is rheumatoid arthritis. It is a multi-system disorder involving so many systems in the joint. It is not confined to joint, but the primary target is joint. Females are affected more than males and patient usually present around the age of 40 to 60 years. In contrast to osteoarthritis, where the primary target is articular cartilage, here in rheumatoid arthritis the primary target is synovium. So the initial event here will be synovitis. Later on there is articular cartilage damage. In osteoarthritis, first there is articular cartilage damage, then there is synovial involvement. So what happens in rheumatoid arthritis? As you all know, it is an autoimmune disorder. There will be development of some of the autoantibodies against self-antigen. So what happens? In genetically predisposed individual having HLA-DR1, DR4, some of the environmental factors like smoking and infections, they trigger the development of autoantibodies against self-antigens. And the two important target antigens are cyclic citrullinated peptides, that is collagen, we maintain fibrinogen and filgrin. Antibodies against these self-antigens are developed, leading to anti-CCP antibodies. The second target is IgG, especially FC portion of IgG, and there is development of autoantibodies, IgM type of autoantibodies against FC portion of IgG, known as rheumatoid factor. So this rheumatoid factor and anti-CCP antibodies, these are the two important antibodies against self-antigen which are responsible for pathogenesis. So what will happen? There will be binding of these autoantibodies again with antigen to form immune complex, and that immune complex will be deposited into various systems of the body, and in joint the primary target will be synovium. So what will happen in the synovium? That immune complex will get deposited and that will induce an inflammatory reaction. So primary reaction will be synovitis. So what will happen? The pathology will start in synovium due to deposition of immune complex leading to synovitis. Due to inflammation, there will be proliferation of synovium, synovial hypertrophy, along with formation of granulation tissue as there is chronic inflammation. So that granulation tissue along with hypertrophy synovium is known as pannus. Here you can see thickened synovial membrane along with granulation tissue, that is known as pannus. Now this pannus will secrete some of the hydrolytic enzymes, as well as there is inflammation in the joint that will lead to destruction of cartilage. So underlying cartilage will get damaged. Finally, there will be erosion of underlying bones. Here you can see. And if left untreated, the final outcome will be fibrous ankylosis, that is fusion of joint by fibrous tissue. There will be development of fibrous tissue which will lead to fusion of joint and complete stiffness. So this is the basic pathology. So what happens? First there is synovium involvement, synovitis, then there is involvement of articular cartilage. Whereas in osteoarthritis, first articular cartilage is involved and later on synovium is involved. Now joints involved. Usually rheumatoid arthritis is considered as a disorder of small joints of hand and feet, and these are the hand joints which are involved most commonly. So in hand there is involvement of proximal interphalangeal joint, metacarpophalangeal joint and wrist joint, and with typical sparing of distal interphalangeal joint and first carpometacarpal joint. Now you will always get confused between osteoarthritis and rheumatoid arthritis, primary osteoarthritis and rheumatoid arthritis, that which joints are involved in hand. So you will have to remember 5 joints from distal to proximal. Distal interphalangeal joint, proximal interphalangeal joint, metacarpophalangeal joint, first carpometacarpal joint of thumb, and wrist joint. So distal to proximal, these are the 5 joints you will have to remember. Now osteoarthritis and rheumatoid arthritis. As osteoarthritis, alphabetically it is before R. So distribute these 2 joints to the osteoarthritis. Now we have given 2 joints to osteoarthritis. To compensate that, we will give 2 joints to rheumatoid arthritis. So spare this joint, give these 2 joints to rheumatoid arthritis. Now we are remaining with 2 joints. Once again, give it to osteoarthritis and give it to rheumatoid arthritis. So now in rheumatoid arthritis you can see PIP, MCP and wrist joints are involved. First carpometacarpal and distal interphalangeal joint are spared. Now in osteoarthritis, DIP, PIP and first carpometacarpal joints are involved. This MCP joint and wrist joints are spared. So this is how you can remember. So we have discussed hand joint, PIP, MCP, wrist joints are involved, DIP and first carpometacarpal joints are spared. Now in foot joint, there is involvement of MTP joints and interphalangeal joints. Amongst large joint, there is involvement of knee, hip, elbow and shoulder. And in spine, there is characteristically involvement of cervical spine, particularly proximal part of cervical spine, which can lead to atlantoaxial dislocation. Now, one of the characteristic feature of rheumatoid arthritis and all inflammatory arthritis is symmetrical involvement of joint. That is, whole part of the joint is involved simultaneously. That is why in knee joint rheumatoid arthritis you will get genu valgus, because we have normally genu valgus. So whole part of the joint is involved simultaneously. There will be genu valgus only. Now this is about symmetrical involvement of one joint. Now the symmetrical in relation to rheumatoid arthritis is also used in a other way, that is bilateral symmetrical. So in a joint there is symmetrical involvement as well as there is bilateral symmetrical involvement. Joints of both hand will be involved simultaneously. So symmetrical involvement of joint as well as bilaterally symmetrical involvement of joint. That is characteristic feature of rheumatoid arthritis. Now clinical manifestations. First we will discuss manifestations of joint. There is pain which is inflammatory type of pain. Okay, in osteoarthritis, which was the mechanical disorder where pain was mechanical type. Here there is inflammatory type of pain. So what is inflammatory type of pain? Inflammatory type of pain is pain which is associated with stiffness, and characteristically the pain and stiffness improves by activity but not by rest, exactly opposite to osteoarthritis, which was the mechanical pain. As there is inflammation, there will be local signs of inflammation like redness, tenderness, warmth and swelling. All four signs of inflammation, celsus signs of inflammation. And the patient may present with various deformities. Important deformities in rheumatoid arthritis, and in every exam they are asking, in your PG entrance exam, every exam they are asking these deformities. In hand, we have swan neck deformity where there is hyperextension at proximal interphalangeal joint and flexion at distal interphalangeal joint. Bottonius deformity or buttonhole deformity, exactly opposite. Flexion at proximal interphalangeal joint and hyperextension at distal interphalangeal joint. Z deformity, ulnar deviation of fingers on ulnar side and radial deviation of wrist, so giving typical Z shape appearance, Z deformity in hand. At elbow there will be flexion deformity. In knee, initially there will be flexion, later on there will be triple deformity. Due to IT band contracture, there will be three deformities: flexion of knee, posterior subluxation of tibia and external rotation of tibia. So later on there will be triple deformity along with genu valgus. In ankle there will be quinus, and in feet there will be hallux valgus, that is distal part of great toe is deviating away from midline. Hallux valgus. There will be hammer toe, that is flexion contracture of proximal interphalangeal joint of second to fifth toe. So these are the important deformities in rheumatoid arthritis. And this swan neck deformity and botonier deformity, they are asking again and again and again in your PG entrance examinations. Now, extra articular clinical features. As there is inflammation, there will be systemic signs of inflammation: fatigue, weight loss, fever, anorexia. Subcutaneous nodules, that is rheumatoid nodules, are there which are non-tender on extensor surfaces. In eye, there may be dry eye, which is the most common symptom. There may be scleritis. There will be involvement of respiratory and cardiovascular system. In neurological system, there can be mononeuritis multiplex, carpal tunnel syndrome, and atlantoaxial dislocation causing spinal cord damage. Now, this is the criteria, old criteria of American Rheumatism Association criteria, which you must be reading in your medicine also. And there is new criteria, 2010 criteria, which is the clinical criteria that you must be reading in your medicine. So here 4 out of 7 are required for diagnosis. Morning stiffness more than 1 hour. Arthritis of 3 or more joints. Among these 7 joints: proximal interphalangeal, metacarpophalangeal, wrist, elbow, knee, ankle, and metatarsophalangeal joints. There is arthritis of hand joints. At least among these, one should be of hand joint. Symmetrical involvement of joint with bilateral symmetrical arthritis. Presence of rheumatoid nodule. Presence of serum rheumatoid factor. And on X-ray, periarticular osteopenia or erosion, especially of joints of hand and wrist. So this is the criteria. Now radiological features. Inflammation induces bone resorption. So earliest radiological feature will be periarticular osteopenia. Earliest radiological feature in osteoarthritis: reduction in joint space. Here the earliest radiological feature is periarticular osteopenia because there is inflammation. Here you can see around metacarpophalangeal joint, this is the normal bone density. Here decreased bone density on both sides. This is normal. Radiolucent area around joints, metacarpophalangeal joints. So these are periarticular osteopenias. Due to resorption of bone, there will be erosions of the bone around there. So here you can see periarticular erosions of the bone. As later on there is damage to articular cartilage also, so there will be reduction in joint space which is symmetrical, in contrast to osteoarthritis where there is asymmetrical involvement, medial side more than the lateral side. And due to synovitis and synovial effusion, sometimes you may get soft tissue swellings around the joint. Treatment: most of the time it is the medical treatment only which is required. Disease modifying agents for rheumatoid arthritis: these are methotrexate, leflunomide, sulfasalazine. Biological response modifier like infliximab, anakinra, rituximab, and corticosteroids, along with physiotherapy. If there is no improvement by medical treatment or there is severe deformity, in those cases surgery is required. For knee, total knee replacement. For hip, total hip replacement. Sometimes in early stages of synovitis, we can do arthroscopic synovectomy. And if patient is not fit for any of these, arthrodesis can be done. Okay. So this is the table showing important differences between osteoarthritis and rheumatoid arthritis. Osteoarthritis primarily degenerative disorders, whereas rheumatoid arthritis is an inflammatory joint disorders due to autoimmunity. Age group in osteoarthritis, as the most important risk factor is increasing age, so mostly patients are old, whereas in rheumatoid arthritis they are slightly younger than patients of osteoarthritis. And sequence of involvement: primary target in osteoarthritis, articular cartilage, later involvement of synovium. In rheumatoid arthritis, the primary target is synovium. Synovitis is early pathology, followed by damage to articular cartilage. As the primary initiating event is not inflammation, signs of inflammation are absent, whereas they are present in rheumatoid arthritis. The pain will be mechanical type of pain with activity on weight bearing, improved by rest. Whereas in rheumatoid arthritis, it is inflammatory type of pain. Pain and stiffness, which is improved by activity but not by rest. And in osteoarthritis, there will be response by new bone formation like subchondral sclerosis and osteophytes. In rheumatoid arthritis, there will be bone destructions like periarticular osteopenia and bone erosions. ESR and CRP will be normal because hematological marker of inflammation are normal in osteoarthritis, whereas due to inflammation they will be raised in rheumatoid arthritis. So these are the important differences between rheumatoid arthritis and osteoarthritis. Now the final important joint disorder, ankylosing spondylitis, also known as Marie-Strumple disease, usually seen in young males, and there is strong association with HLA-B27. It is primary disorder of axial skeleton, and the most common joint involved is sacroiliac joint, followed by spine, lumbar, thoracic, cervical. Sacroiliitis is earliest pathology. In peripheral joints, it usually involves only large joints like hip, shoulder, elbow. Small peripheral joints of hand, feet and wrists are characteristically spared. It can also involve costovertebral joint, which can lead to decreased chest movement, decreased chest expansion. And one of the characteristic pathological findings is enthesitis or enthesopathy, that is inflammation in the bone at the site of attachment of ligaments or insertion of tendon. For example, if this is calcaneum, there will be insertion of tendoachelis. So at this particular site there will be inflammation. This is known as enthesopathy. At the site of attachment of ligament or tendon, there is inflammation. Clinically, this will be the most typical presentation. Most of the time young male, female, there can be female also, but most of the time young male in third decades or early fourth decades, presenting with typically inflammatory type of back pain and back stiffness. So once again, what is inflammatory type of back pain? The pain and stiffness in back which is improved by activity, not by rest. So that is inflammatory type of back pain. Okay, morning back stiffness which will improve with activity, not by rest. If there is fusion of spine or joints, patient may present with abnormal posture like forward stooping gait due to kyphotic deformity in spine or fusion of hip in flexed position. So patient may walk with forward stooping gait. There may be reduced chest movement. There are few clinical tests described. Schober's test or modified Schober test, which is to check lumbar spine flexion, where posteriorly we mark at posterior dimples, which is the site of posterior superior iliac spine, and two other lines 10 centimeter above that line and 5 centimeter below that line. So the total distance between proximal most and distal most line is 15 centimeter. Now we ask the patient to bend forward with knee in extended position. Normally this distance between proximal most and distal most line should increase more than 5 centimeter. So final distance should be more than 20 centimeters. If this distance is less than 20 centimeters, like in this figure 15 to 17 centimeter, that means lumbar spine flexion is reduced. So this is modified Schober test. Due to involvement of costovertebral joint, there will be decreased chest expansion, which you measure at the level of nipple. With measuring tape, you measure at the end of full expiration and at the end of full inspiration. This difference should be more than 5 centimeter normally. But in ankylosing spondylitis, if there is involvement of costovertebral joint, this chest expansion is reduced. To check cervical spine mobility, we do flash test or occipit to wall test, where the patient is standing against the wall with back touching the wall, and we ask the patient to touch the occipit to the wall. If there is cervical spine fusion, the patient will not be able to touch the wall because of stiffness in the cervical spine. So this is flesh test or occipit to wall test. Now the other important tests which are for sacroiliac joint. The basic idea of all these tests is to put stress on sacroiliac joint. If there is sacroiliitis, the patient will be having pain. The method of doing these tests is different, but the basic idea is same, to put stress or strain on sacroiliac joint. So one is pump handle test, where we flex the knee and hip of the patient and try to touch the opposite axilla. Second is Gien slant test, where patient is supine at the edge of table. We fix the pelvis by flexing the opposite side of hip, and then on affected side we do extension. Pelvic compression test, we compress both anterior superior iliac spine towards each other. Patrick test or Faber test, where we do flexion, abduction, external rotation of hip. In all these tests, we are putting stress on sacroiliac joint. If patient of ankylosing spondylitis is having sacroiliitis, there will be pain in sacroiliac area. Radiologically, the earliest manifestation will be sacroiliitis, where you will find these erosions in sacroiliac joint and sclerosis around sacroiliac joint. So erosion and sclerosis around sacroiliac joint, that is sacroiliitis. And some of the findings in spine. Squaring of vertebra. Normally the anterior border of vertebra is slightly concave. It becomes straight. So this is known as squaring of vertebra. There will be bridging osteophytes at the margin here, known as syndesmophytes. They are known as bridging osteophytes because they bridge the gap of intervertebral disc. If they touch each other and they lead to fusion of large segment of spine, the spine looks like a shaft of a bamboo tree. So bamboo spine. Okay. So what are the findings? Sacroiliitis, squaring of vertebra, syndesmophytes and bamboo spine. Now some of the extra-articular manifestations are there. There may be anterior uveitis, aortic regurgitation or aneurysm. There may be neurological involvement, or there may be respiratory tract involvement. Here also, most of the time it is conservative treatment which is required, like NSAIDs. Most commonly used NSAIDs in ankylosing spondylitis is endomethacin. If there is acute exacerbation, we can also use corticosteroid. And if patient is not responding, we add biological response modifiers. For severe deformity of spine or fusion of hip, surgery is indicated, like correction of spine deformity by osteotomy and total hip replacement for fused hip joint. Okay, so this was about important joint disorders. If any one of you beta have any query in joint disorders, you can ask me. Then we will proceed to next chapter, that is pediatric orthopedics. Yes beta, anyone? Okay, so let's start with next chapter, that is pediatric orthopedics, where we will discuss some of the important traumatic pathologies like green stick fracture, torus fracture and physial injuries, and some of the most important known traumatic pediatric disorders like development dysplasia of hip, Perthes disease, slip capital femoral epiphysis and CTEV. Now all these are very important, very important. Okay, these are very important for your university exam as well as for your PG entrance examination. Now, so first start with traumatic part. There are two important incomplete fractures in children. One is green stick fracture, the second is torus fracture. So what is green stick fracture? Green stick fracture is incomplete transverse fracture, where one cortex is broken but the opposite cortex is intact. Whenever there is bending force in pediatric bone due to capacity of plastic deformation, there is break in one cortex first before completing the fracture, and it looks like a break in fresh green wood whenever you are trying to bend it. That is why it is known as green stick fracture, and due to bending force. Now important thing here should remember, it will be in the shaft area, diaphyseal area. Treatment is just give opposite stress. You straighten the bone and give cast. Okay, remember in some of the textbook they have given complete the fracture then give cast. No, this area of it will act as a hinge and stabilizing force if you correct the deformity and give the cast. Okay, some of the textbook they have given complete the fracture then align it. No, correct the deformity, give the cast. So this is the first incomplete fracture. The second incomplete fracture is torus fracture, where there is buckling of metaphysis at metadiaphyseal junction, and it is due to axial pressure. Okay, so there is buckling of cortex. It is also known as buccal fracture. It is due to axial force, and here just immobilization is required either in slab or cast. So what are the differences between this green stick fracture and torus fracture? These are the most common fracture patterns in children, especially in radius ulna. In green stick fracture, it is due to bending force, whereas in torus fracture, it is due to axial force along long axis of bone. In green stick fracture, fracture will be in shaft area, whereas in torus fracture, it will be in metaphyseal area at the junction of metaphysis diaphysis. So these are the two important incomplete fractures in children. Now the other commonly injured area in children is this growth plate or physis, because it is hyaline cartilage, and cartilage is always weaker than bone. That is why this area is particularly prone for the injury after trauma in children. And this physial injury is classified by Salter and Harris into 5 types. Type 1, there is separation through physis. So this is metaphysis, this is physis, this is epiphysis, physis or growth plate. So there is separation through physis. So only physial damage is there. In type 2, there is fracture of this metaphyseal area, here you can see, and separation through physis. So here physis plus metaphysis are involved, and this triangular fragment of bone on X-ray, it is known as Thurston-Holland sign. Okay, Thurston-Holland sign is seen in type 2 physial injury where there is triangular metaphyseal area. Now this type 2 injury is the most common type of physial injury in children. Type 3, here metaphysis is intact but injury to epiphyseal area and physis. So epiphysis along with physis. Type 4 will involve all of these 3. Epiphysis plus physis plus metaphysis. Now type 5 injury, severe crush injury to physis. So there is crushing of physis. Only physis is involved but that is severely crushed, completely damaged. There are no chances of recovery. That is complete damage. So there will be severe growth disturbance in length of the limb. So type 1 only physis, type 2 physis along with metaphysis, type 3 physis along with epiphysis, type 4 all three, and type 5 severe crushing of physis. Now this type 1 injury and 2 injury, they have good prognosis because the epiphyseal site of cartilage, there is no damage. There is damage from this side, and this epiphyseal site of cartilage, this has resting zone or quiescent zone from where there is proliferation of cartilage which can lead to regeneration of cartilage. So that is why these two, type 1 and type 2, have good prognosis. And if these are undisplaced, most of the time just simple immobilization is required. If these are displaced, in that case you require reduction and percutaneous pinning, otherwise most of the time just immobilization. Now type 3 and 4, as injuries from epiphyseal site. So epiphyseal site of cartilage is also damaged. From which side there is recovery. So they have poor prognosis because the layer of their layer of physeal cartilage which leads to regeneration, quiescent zone or resting zone, which is on epiphyseal side, that is also damaged. So prognosis is poor. Here always either close reduction or open reduction along with K-wire fixation is required. Now type 5 is having worse prognosis because there is severe crushing of physis or growth plate. There are no chances of recovery. All layers are severely damaged. So you cannot do anything for this type of injury. Okay. Now we will discuss important non-traumatic pediatric disorders. The first disorder which we are going to discuss is Perthes disease. So Perthes disease. What is Perthes disease? Perthes disease is osteochondrosis of epiphysis of femoral head. Now remember, in some of the textbooks they have given osteochondritis. Now these two are different terms, osteochondrosis and osteochondritis. So to better understand this topic, you should understand all long bones, they are developed from ossification centers. Primary ossification center for diaphysis and secondary ossification centers for various epiphysis. So what happens? First there is formation of cartilage around this center. Then there is ossification of that cartilage known as endochondral ossification. Okay. This is how bone is formed. Now what happens in osteochondrosis? This blood supply of this either secondary or primary ossification center is defective, leading to avascular necrosis of that particular center. If it is for secondary ossification center, it will affect epiphysis. Like in Perthes disease. Perthes disease affect epiphyseal center, that is secondary center for femoral head. So in layman language, there will be avascular necrosis of femoral head in growing skeleton. That is osteochondrosis. Now what is osteochondritis? As the name is suggesting, itis, chondro, inflammation of cartilage. So this is osteochondritis, means inflammation of intra-articular cartilage. And some of the osteochondrosis which are intra-articular, like this Perthes disease, head will be inside the joint. They can cause inflammation in the cartilage. So they can cause osteochondritis. But primarily they are osteochondrosis. Okay. So remember, in textbook also sometimes they have incorrectly mentioned that. These are osteochondrosis, not osteochondritis. So here in Perthes disease, it is osteochondrosis of epiphysis of femoral head, leading to avascular necrosis of femoral head. And all those disorders, Penner's disorders, which we are going to discuss later on, those are osteochondrosis, not osteochondritis. Osgood-Schlatter's, Penner's, Sevius disease. Okay. So those are incorrectly mentioned as osteochondritis. Those are osteochondrosis. This Perthes disease is the most common type of osteochondrosis. Etiology is unknown, but pathogenesis is known. Pathogenesis is defective blood supply to secondary ossification center of femoral head, leading to avascular necrosis. This disease is self-limiting. What do you mean by self-limiting? Self-limiting means the persistent disease has its own course. You cannot cure the disease. As it has its own course, you can control the final outcome. So what will happen first? There will be avascular necrosis due to defective blood supply, then resorption of this necrotic bone, and then formation of new bone at the site of resorption. Okay, so if during this whole process, in this course of disease, you contain the head inside the acetabulum, okay, so concentrically in hip joint, so what will happen? There will be normal mechanical stresses. So during this process, there will be proper remodeling of bone. So final outcome will be spherical head formation if you are doing containing of head inside the joint. So we can control the outcome, but we cannot cure the disease. So this is a self-limiting disorder. The usual age group is 5 to 10 years, affecting male more than females. It is bilateral in 10 to 20% of the patient. Clinically, child will be in the age of 5 to 10 years, and the typically described presentation is painless limb. Okay, most of the time child will be coming with painless limb. Okay, Sohan beta, so I missed your question beta. Let me finish this pediatric orthopedics, then I will tell you. Okay. So I missed your question beta, I did not see your question. So classical described presentation is painless limb. But sometimes there may be pain also. So patient may also present with painful limb. And if there is pain, it may radiate to hip joint. To knee joint, because hip joint and knee joints, they are supplied by articular branches of obturator nerve. So through obturator nerve, the pain of hip joint can be radiate to knee joint. Typically there is limitation of abduction, internal rotation and extension. So presenting deformity will be due to limitation of abduction, there is adduction. Due to limitation of internal rotation, there is external rotation, and due to limitation of extension, there will be flexion deformity. So the presenting deformity will be flexion, adduction and external rotation. If there is destruction of head, there will be shortening of limb, and Trendelenburg test will be positive. You ask the patient to stand on the affected side, the opposite side pelvis will be sagging down. So these are the clinical features of Perthes disease. On X-ray, you will find lateral subluxation of head. Because of lateral subluxation, there will be increase in medial joint space between femoral head and acetabulum. So lateral subluxation along with increase in medial joint space and fragmentation of head. Typical X-ray of Perthes disease. The investigation of choice is MRI, which will tell the exact extent of involvement, and also when there is early stage, when X-ray findings are not there, MRI will help us to diagnose the condition, and it will also help us for treatment planning. Now treatment, as we have already discussed, the basic principle is to induce proper remodeling in centric acetabulum. We contain the head concentrically in the acetabulum so that there are normal mechanical stresses of joint. So ultimately during the process of healing, there will be formation of well spherical head. So concentric reduction and containment of head inside the acetabulum is the basic principle. So treatment of choice for Perthes disease, containment of head concentrically inside the acetabulum. Now methods of that containment may be different. If child is having the age of child is less than 7 years, containment is mostly done by conservative method, by abduction, braces or casts. The type of cast I will be showing I will show you in the next slide. If age is more than 7 years, the containment is done by surgical correction. So here you can see, if child is less than 7 years, containment is done by abduction, braces like this Scottish Rite brace or Petri cast or broomstick cast. In both you can see there is abduction. So position of containment where you put the head concentrically in the acetabulum is abduction. So you are giving abduction brace or cast, Scottish Rite brace or broomstick cast or Petri cast. If more than 7 years, surgical containment, varus derotation osteotomy is done. So basic idea is containment of head concentrically in the acetabulum. If less than 7 years, conservatively by abduction, cast or brace. If more than 7 years, surgically. Now we will discuss slipped capital femoral epiphysis. As the name is suggesting, slipping of capital femoral epiphysis. So epiphysis of femoral head slips down. Here you can see this is normal epiphysis. This is physis or growth plate and this is metaphyseal area femoral neck. Now on this side, affected side, this epiphysis of femoral head, it has slipped down. Okay, so that is a slipped capital femoral epiphysis. Actually in real sense it is a misnomer because head is normal in its position well inside the acetabulum. It is the neck which has gone up. When there is separation through this physeal plate, neck is going up. So actually neck is going up, but relatively head is slipping down. That is why we call it as a slipped capital femoral epiphysis. So this is a misnomer. Now most of the time this slip is inferior direction and posterior direction. Due to inferior slip there will be decrease in neck or head shaft angle which is known as coxa vara, and the usual age group affected is adolescent period, 10 to 15 years. Now in adolescent period it is causing coxa vara, that is why it is also known as adolescent coxa vara. Most of the time patients are overweight or obese. I am saying most of the time. Sometimes it may also happen in thin lean patient, but most of the time patients are overweight and obese, and males are affected more than females. Now why this particularly common, why this SCF is particularly common in adolescent period? Because during adolescent period there is growth spurt, and we have discussed so many times, growth in bone occurs in that physeal area, growth plate or physeal area, and during growth spurt there will be increased proliferation of that cartilage. Growth plate is a cartilage, and that thickness of cartilage will increase during this period, adolescent or growth spurt period. So what will be happening? This growth plate thickness will increase. As you all know, growth plate is cartilage and cartilage is always weaker than the bone. As there is increased thickness of this cartilage, this area will become particularly weak. Especially in obese patient, whenever there is weight bearing, there can be separation through this physeal cartilage. So there will be slipping of head down through physeal cartilage. That is why it is more common in adolescent period and especially in overweight patient. There may be associated endocrinopathy like hypothyroidism, hypogonadism, acromegaly or exogenous use of growth hormone. It is bilateral in 30 to 40% of the patients. Clinically, patient will be presenting with painful limp, and there will be restriction of abduction and internal rotation. And one of the characteristic feature of this SCFE, it is the only condition around hip joint where there will be restriction of flexion also. Extension will be free. In all other hip pathologies, most of the time you will see patient is presenting with flexion deformity. Extension is restricted. Whereas in SCFE, it is flexion which is restricted, extension is preserved. So any adolescent patient slightly overweight, on clinical examination, flexion is restricted but extension is free, always think of slipped capital femoral epiphysis. Okay, so deformity will be due to restriction of abduction, there is adduction. Due to restriction of internal rotation, there is external rotation. So patient will be presenting with adduction and external rotation. The other important finding on clinical examination, on flexion of hip, the hip will go into external rotation and abduction because flexion is restricted. There cannot be normal flexion. So instead of going straight flexion towards the same side shoulder, it will go into external rotation like this, also known as knee axilla sign or obligatory external rotation. Obligatory external rotation. Tendenbach test will be positive. So these are the important findings. So to remember SCFE, you will have to remember 5 important points which are very specific. First, adolescent age group. Second, obese or overweight. Third, associated endocrinopathy like hypothyroidism. Fifth, you should remember this very important clinical examination. Clinically, you can exclude everything if there is limitation of flexion. Extension is free. So, limitation of flexion. And finally, obligatory external rotation. So remember these 5 things, SCFE is over for you. Okay. On X-ray, the earliest investigation of choice, first investigation of choice always will be frog leg lateral view, where you will find simply lateral X-ray of hip joint, where you can see this is normal head neck shaft angle. Here it is decreased. So this X-ray, frog leg lateral X-ray will always show you this slipped epiphysis. And on AP X-ray, you remember this Trethovan sign. Normally, whenever the upper margin or superior border of neck, you prolong it proximally, it will bisect the head. Here you can see, it will bisect the femoral head. But in slipped capital femoral epiphysis, this line will go way above this epiphysis. It will not bisect this femoral head epiphysis. Okay, so this line is known as Kleins lines. It will pass above the epiphysis. This is known as Trethovan sign. MRI is the most sensitive investigation which can detect the SCFE at earliest, but it is not the investigation of choice, because most of the time diagnosis can be confirmed just by clinical examination and X-ray. So radiological investigation of choice is frog leg lateral X-ray view. Patient is coming to you, clinically you find it is SCFE, take out frog leg lateral view. If you have any doubt, then MRI, otherwise your diagnosis can be confirmed with clinical as well as radiological X-ray findings. Treatment, most of the time in acute slip we do close reduction with percutaneous spinning so that there is no further slipping. And as the condition is bilateral in 30 to 40% of cases, we do prophylactic pinning of opposite side, because if patient is presenting with unilateral SCFE, there are 30 to 40% chances that patient will develop the other side also. So other side we will be doing prophylactic pinning. This was about slipped capital femoral epiphysis. Now the next pediatric disorder which we are going to discuss here is development dysplasia of hip. Previously we used to call it as congenital dislocation of hip, but that is a misnomer, not correct term. Congenital means presenting since birth, but in development dysplasia of hip, sometimes dislocation may occur after birth, sometimes after birth, not exactly at birth. So the better term is development dysplasia of hip, where this plastic development around hip joint leads to instability of hip joint. Okay, so due to that there may be dislocation of femoral head out of the femoral cavity, out of the acetabular cavity, and most of the time the dislocation is superolateral and in posterior direction. So posterior superolateral direction. Risk factors. To remember risk factors, you will have to remember 4F and 1O. Firstborn child, female fetus, they are more prone for dislocation because of relaxin hormone from mother. Now some of you may argue that when the hormone is coming from the mother, it will also come in male fetus also, because it is coming from the mother, transplacental. Then why the female fetus is affected more than male fetus? Can anybody tell me, beta? Anybody? Okay, this is because relaxin is a female hormone. Receptors are present only in female fetus, not in male fetus. That is why, though it is coming from mother, it will affect female fetus. There is familial tendency. There is faulty intrauterine position, mostly breech delivery. So 4F, firstborn, female child, female fetus, faulty intrauterine position like breech delivery, and familial tendency. And 1O, oligohydramnios. These are the important risk factors for development dysplasia of hip. Okay, so twin pregnancy is not a risk factor for development dysplasia. Twin pregnancy is not considered as a risk factor. It is bilateral in 20 to 30% of cases, and in unilateral cases left side is involved more than right side. The pathology, the basic and primary pathology is shallow and wide acetabulum. This is the basic and primary pathology. Other associated pathologies are small femoral head. There is excessive anteversion of femoral neck. There is hypertrophy of ligament of teres. The limbus, that is fibrocartilaginous rim around acetabulum, is inverted. There may be stretching of hip joint capsule and tightening of adductor muscles. So these are the various important pathologies which you will find in development dysplasia of hip. Clinically, there will be asymmetrical thigh fold. On the involved side, you will find more thigh fold. Here you can see, this is the affected side. You will find more thigh folds, asymmetrical thigh folds. Here only 2, here you can see 1, 2, 3. So asymmetrical thigh folds and gluteal fold on the affected side will be higher than the normal side. So asymmetrical thigh folds, gluteal fold higher than normal. And if child can walk, that is in older child will be walking with Trendelenburg gait, that is drifting on the affected side of limb. If it is bilateral condition, there will be duck-like gait known as waddling gait, drifting on both sides like this. So bilateral case is bilateral, case is DDH, waddling gait or duck-like gait. There is increased lumbar lordosis, and on examination there will be limitation of abduction and external rotation. And we are going to read that in posterior dislocation of hip, traumatic posterior dislocation of hip, where you will find Fadir deformity, flexion, adduction, internal rotation. This congenital dislocation is also posterior dislocation. So here also you will find Fadir deformity, flexion, adduction, internal rotation. Okay. In traumatic posterior dislocation also you will have Fadir deformity, and there may be positive vascular sign of Neurath. What is vascular sign of Neurath? Normally, whenever you are palpating the femoral pulse, in inguinal region, the posterior bony support, counter pressure, is provided by femoral head. If there is dislocation of hip, that posterior bony support is not there at its place. So either femoral pulse is feeble to palpate or not palpable at all. So this is known as vascular sign of Neurath. Important clinical test in your textbook. Two important tests are described: Barlow's test and Ortolani's test. What we do in these tests, in flex position of hip and knee, first we try to dislocate the hip by adducting the hip. So if we are doing adduction of hip, it may get dislocated. This is known as Barlow's test. So there will be clunk of exit, either audible or palpable clunk of exit. This is Barlow's test. Now opposite we will be doing in Ortolani's test, where we will be doing abduction and we will try to reduce the dislocated hip. So here we will be doing adduction and trying to, on abduction we are trying to reduce the hip. So in this test there is either palpable or audible clunk of entry. So in Barlow's test we are provoking the pathology, we are dislocating the hip. So that is why this Barlow's test is the provocative test. Okay, where we are dislocating the hip. Ortolani's test is where we are reducing the hip. Now other important signs and tests which are not given in your textbooks: heart sign or abduction test, where on affected side of hip abduction is restricted. Normal side you can touch the knee to the couch by doing abduction. On affected side it is restricted. And we have seen Fadir deformity, there is adduction deformity, so abduction is restricted. So this is abduction test or heart sign. Galeazzi sign or Ellis sign, on flexion of hip and knee, the affected side knee will be at lower level than the normal side of knee. This is known as Galeazzi sign or Ellis sign. The other are telescoping. In 90 degree of hip and knee flex position, if you give axial pull and push, as head is outside the acetabulum, there will be excessive movement like telescope. Telescoping will be positive. If child can stand on one limb, Trendelenburg test will be positive. You ask the child to stand on the affected side, the opposite side, non-weight bearing side pelvis will sag down. This is Trendelenburg test. And details of these tests we will be discussing in the last chapter, that is various important tests in orthopedics. These were the clinical tests for development dysplasia of hip: Barlow's test, Ortolani's test, heart sign or abduction test, telescoping, Trendelenburg test, Galeazzi sign or Ellis sign. Now radiologically, the screening procedure of choice is dynamic ultrasonography, because during first 6 months of life X-ray will show you nothing. So diagnosis is done by dynamic USG. On X-ray everything will be normal, because most of the part around hip joint will be cartilaginous, and cartilage you cannot see on X-ray. So that is why dynamic ultrasonography is the investigation of choice. On X-ray, especially on antero-posterior X-ray, there are some important findings. You will have to draw two lines: Perkins line and Hilgen-Renal lines. Perkins lines, what is Perkins line? This is acetabulum, this is acetabulum, one vertical line from outer edge of acetabulum on both sides. This is Perkins line. Now Hilgen-Renal line, one horizontal line through triradiate cartilage, upper margin of triradiate cartilage. So this is Hilgen-Renal line. The third line you will draw is Shenton's line. What is Shenton's line? From the medial margin of femoral neck, if you prolong it along superior margin of obturator foramina, this is continuous line. Now if you have drawn these three lines in a child of DDH, what will you see? This head, you can see this femoral head epiphysis. This is in upper outer quadrant. Normally it is in lower inner quadrant, but in DDH is in upper outer quadrant. And The non-normal side, this is continuous Shentel line. On this side, there is break in Shentel line. This line cannot be continuous. So head is in upper outer quadrant and break in Shenton's line. These are the important X-ray finding on AP X-ray. Now one special view is von Rosen view, where in 45 degree of abduction, 45 degree of abduction and full internal rotation, you take anterior-posterior X-ray, and on normal side, if you draw long axis of femur, it will touch the upper margin of acetabulum and will traverse through sacroiliac joint. In development dysplasia of hip, this is acetabulum. This line will pass way above this acetabulum and in lumbar region, not in sacroiliac joint. So this is known as von Rosen line and this is von Rosen view. So von Rosen line and von Rosen view are related to development dysplasia of hip. Now management in all dislocations, whether it is traumatic or congenital, the primary basic to treat is same: reduce the joint concentrically inside the joint cavity. So here early concentric reduction of femoral head in acetabulum and then maintenance of that reduction. And method of reduction will depend on the age of the child. So here are various age groups. First is 1 to 6 months, second is 6 to 18 months, third is 18 months to 3 years, and last is 3 to 8 years. If you just remember this age group, it is very easy to remember the treatment. Okay, you just remember age group. So first age group, 1 to 6 months, close reduction of hip joint followed by maintenance of that reduction either in Pavlik harness, this is Pavlik harness which is preferred, or in von Rosen splint. Next age group, 6 to 18 months, you can try close reduction, but most of the time either it will redislocate or you will not be able to achieve close reduction. So most of the time open reduction, and then maintenance of that reduction is either frog leg cast or bachelor's cast. Next age group, only open reduction will not help. Some of the bony procedure will be required. So here open reduction along with varus derotation osteotomy of femur. Next age group, only femoral osteotomy will not help. You will have to add some acetabular osteotomy also. So here open reduction, femoral osteotomy along with some acetabular osteotomy, Salter's, Chiari's or Pemberton's osteotomy. Okay, so how to remember? You remember just age group, 1 to 6 months, close reduction. Next age group, next procedure, that is open reduction. Next age group, along with open reduction you will have to add femoral osteotomy. Next age group, along with this procedure add acetabular osteotomy. So with increasing age group you add next level of surgery: close reduction, open reduction plus femoral osteotomy, open reduction, femoral osteotomy plus acetabular osteotomy. If you remember the age group, you can easily remember these treatment of choices. Now the next and the final pediatric disorder which we are going to discuss is congenital talipes equinovara, CTEV or club foot. Why it is called as club foot? Because foot looks like head of a golf club, so it is same. That is why it is known as club foot. Now what are the deformities in club foot? Equinus, that is plantar flexion of the foot, and equinus occurs at ankle joint, that is tibio-talar joint. Then there is inversion, that is sole of the foot is facing inward, which occurs at subtalar joint. Subtalar joint is talocalcaneal joint. Forefoot adduction, that is the front part of the foot is going medially. This movement occurs in mid-tarsal joint, that is joint between tarsal bone, here in this area, but you can see deformity in the front part of foot, because you can look at this area only. So though the movement is at mid tarsal joint, there is adduction of forefoot. Finally, there will be excessive arching of the foot, cavus. So these are the four basic deformities: equinus, that is plantar flexion; inversion, sole is facing inward; adduction, the forefoot is going medially; and cavus, excessive arching. Now this inversion and adduction of foot, combination of these two is known as varus. Now if we combine this varus with this equinus, so these three, combination of these three is known as supination. So you will have to remember these 6 deformities: supination, varus, equinus, inversion, adduction, cavus. If sometimes you are getting confused, in your hand you must be knowing supination is like this, palm is facing towards the roof. If you are getting confused, you do supination at your foot. Try to move your sole towards the roof. You look at your foot, you will find all these. There will be plantar flexion, that is equinus. You try to do it right now. Try to supinate the foot. There will be plantar flexion, there will be inversion, forefoot will be going into adduction, and you will have excessive arching in your foot. Have you tried, beta? Some of you have tried. Try to supinate your foot. You will find all these. So if you are getting confused, try to supinate your foot and look at your foot. You will find all these: equinus, inversion, adduction, cavus. Okay. Now it is the most common congenital anomaly of foot. Males are affected more than females, especially first born male child, and it is bilateral in half of the cases. In unilateral cases, right and left sides are affected equally, and it may be associated with fetal malposition like breech delivery and oligohydramnios. The primary pathology, primary abnormality in CTEV is subluxation of talonavicular joint. That is why whenever we are correcting the deformity, like in Ponseti method, this talonavicular joint we use as a fulcrum. We correct the deformity at the place where exactly the deformity is. That is why Ponseti method is more successful. Now causes wise, CTEV can be divided into primary, idiopathic type, where is no known cause and which is the usual type of CTEV. And whenever we are using the term CTEV, we are concerned about this idiopathic unless otherwise specified. Here the CTEV is the only manifestation. Now the other is secondary CTEV, where there is either some primary neuromuscular disorder or some other cause leading to CTEV as a secondary deformity, like neurological disorders, neural tube defect, that is spina bifida, paralytic disease like poliomyelitis or myelodysplasia, arthrogryposis multiplex congenita, where there are multiple contractures around the joint, and Larsen syndrome. Now the management part is the most important part in CTEV. Before going management, you should understand various terms. Fresh case of CTEV means case of CTEV which is coming to you for treatment up to the 9 months of age. Whether the patient has taken treatment or not, if it is coming within 9 months, you consider it as fresh case. Neglected case, where the child has not taken any treatment even up to the age of 1 year, that is neglected, foot has been neglected. A resistant or failure case, where you have given proper corrective attempts to the foot, but it is not getting corrected, so it is resistant to correction. That is why the treatment has failed. So failure or resisting case, you have given the treatment but it is not getting corrected. So treatment of fresh case always is conservative, that is manipulation to correct the deformity, then maintain that correction. And for neglected and resistance cases, you will always require surgery. So if examiner is asking treatment of CTEV, unless other otherwise specified, the examiner is asking about fresh case. So what is the treatment of fresh case? Most of the time we start treatment around 1 week only, that is in newborn period, and treatment of choice is manipulation. You manipulate and stretch to correct the deformity, and followed by maintenance of that correction in the cast, and cast will be above knee cast. For manipulation we have two important methods, Ponseti method and Kites method. Nowadays only Ponseti method is followed because it is the most successful method, and it has scientific reasons for that. Not only just we are following Ponseti method. So in Ponseti method we start the treatment in a week after birth, whereas in Kites method we started 1 month after the birth. And sequence of correction in Ponseti method is cave. But remember, in cave A and V are together. First cavus followed by adduction and varus together, finally equinus. Now this is the basic principle of Ponseti method. We are correcting the deformity together. So this cave is not like C, A, V, E. Okay, A and V are together. So first cavus, adduction and varus, then finally equinus. Whereas in Kites method, cavus was not addressed at all. The correction of deformity was sequentially. They did not address cavus, adduction, varus, and finally equinus. Equinus is the last deformity which is corrected in both types of method. Now in Ponseti method we change the cast every week, whereas in Kites method we change every 2 weeks. Counter pressure at the time of correction is given on talar head in Ponseti method. So fulcrum is talonavicular joint where there is primary pathology. So we are doing correction at the pathological level only. That is why the success rate is more than 90%. Whereas in Kites method we give counter pressure at calcaneocuboid joint, not at talar head. Okay, so we are giving at calcaneocuboid joint and we are doing correction at the forefoot. The primary pathology is talonavicular joint and we are correcting at forefoot. So there is spurious correction. That is why it has poor success rate. Therefore nowadays we use Ponseti method of correction. So what will we do? Child is coming to you, you stretch the cavus, try to correct it by stretching and then apply cast to maintain that stretching. Next time child is coming to you, you correct adduction and varus and immediately give cast, above knee cast, to maintain that stretching. So this is how serially every week you will be giving cast during first 6 weeks, after 6 weeks, every 2 weeks cast. Once all deformities are corrected by correction and maintenance in that cast, you remove the cast, and finally once you have achieved full correction, you maintain that correction after achieving in Dennis-Brown splint until child starts walking. Once the child starts walking, you will give Dennis-Brown splint while the child is in bed and CTV shoe while the child is walking. So what are the various features of CTV shoe? If you remember basic principle, there is no need to mug these features. You can easily understand these features. CTV shoe we have given to maintain the correction. We have achieved the correction. Now we don't want to recur those deformities. So we want to prevent recurrence. For that we have given CTV shoes. So what was there in CTV foot? There was inversion like this. If we will give lateral side, this is lateral, this is medial, this is inversion. If on lateral side we give some raise like this, so there will be prevention of recurrence of inversion. Inversion will not occur. So that is why we give raise lateral border to prevent recurrence of inversion. Similarly, in forefoot we have adduction. Forefoot adduction is there. If we straighten the medial border of shoe, this forefoot cannot go into adduction. So to prevent Recurrence of adduction, we give straight medial border. In CTEV shoe, we have equinus deformity. So if there is heel in the shoe, there can be recurrence of equinus. So we remove the heel from the shoe to prevent recurrence of equinus. So there is straight lateral border, raised lateral border, straight medial border, and no heel. And this maintenance we give up to the age of 5 to 7 years. And after 5 to 7 years, there are very less chances of recurrence. After 5 to 7 years, the child can use normal shoe. So this was the treatment of fresh case of CTEV. Now we will discuss failed cases or neglected cases. In all failed and neglected cases, always surgery is indicated. And surgery up to the age of 4 years is only soft tissue procedures. Posteromedial soft tissue release, PMR or PMSR, posteromedial soft tissue release, also known as turquoise procedure, where we release all tight contracted soft tissues on posterior and medial side. If age of the child is more than 4 years, only soft tissue procedure will not help, because there are some irreversible bony changes also. So along with soft tissue procedure, that is posteromedial soft tissue release, you will have to add some bony procedure also. And between the age of 4 to 8 years, the bony procedure of choice is Dillwyn-Evans or Evans procedure, where we do calcaneo-cuboid fusion. Between the age of 8 to 10 years, the bony procedure is wedge tarsectomy. And more than 10 years, the surgery of choice is triple arthrodesis, triple fusion. We are fusing 3 joints: subtalar joint, that is talocalcaneal joint, calcaneo-cuboid joint, and talonavicular joint. So here are the figures. This is Dillwyn-Evans procedure, where we take out wedge at calcaneo-cuboid joint and we correct the deformity and fuse that calcaneo-cuboid joint. Wedge tarsectomy, between 8 to 10 years, we take out superolateral wedge from the tarsal bone and we correct the deformity and we fuse it, wedge tarsectomy. After 10 years, triple arthrodesis, we fuse 3 joints: subtalar joint, that is talocalcaneal, talonavicular, and calcaneo-cuboid joint. If there is isolated heel varus, Deus osteotomy can be used, where lateral closing wedge osteotomy. We take out wedge from lateral side, we correct the varus, and we straighten the calcaneum, heel bone. Okay, so here is quick recap for treatment of CTEV. Fresh case, treatment of choice is manipulation for correction of deformity and maintenance in above knee cast during manipulation. So remember, maintenance in CTEV is of 2 types. One, maintenance when we are doing manipulations and we are correcting the deformity during initial weeks of life. So we are correcting and maintaining in cast. So individual deformity correction and maintenance of that correction, stretching in cast. Once full correction is achieved, then maintenance in Dennis Brown splint and CTEV shoes. So fresh case, treatment of choice is manipulation for correction of deformity followed by maintenance. In neglected or resistant or failure cases, surgery is required. Up to 4 years, only soft tissue procedure. After 4 years, along with soft tissue procedures, we also require some bony procedure. Between 4 to 8 years, the bony procedure is Dillwyn-Evans procedure, that is calcaneo-cuboid fusion. Between 8 to 10 years, that is wedge tarsectomy. And after 10 years, it is triple arthrodesis, fusion of 3 joints. So this finishes our topic of pediatric orthopedics. If any one of you have any query, you can ask. Okay, and you can subscribe this channel, because now onwards continuously I will take online lectures on YouTube channel, and you can suggest also whichever topics in all subjects, not only in orthopedics. If you want to learn some other topics of other subjects, you can suggest, then I will take lectures of those also. Okay, so here if you have any query regarding this Pediatric orthopedics, you can tell me, beta. Okay, so I will finish my lecture here. The next lecture we will be joining at around 2 o'clock. So you have your lunch. If you want to take some power nap, you take, then join me at 2 o'clock once again. So once again, thank you very much for joining the lecture. And in the evening session, in the evening 2 sessions, we are discussing more important topics for your university exam. So beta, once again, best of luck to everyone for your preparation. See you at 2 o'clock.